You take a little pill every morning for your blood pressure. Your doctor started you on it years ago. The number on the cuff reads fine, so you've never thought twice about it. But if you're also more tired than you used to be, if the weight is settling around your middle no matter what you do, if a flight of stairs leaves you more winded than it should, there's a real chance that pill is part of the reason. And the cuff reading looks perfectly acceptable the entire time, which is exactly why nobody has connected the two. The pill is almost certainly one of a class of drugs called beta blockers. They've been prescribed for high blood pressure for 50 years, and for one specific kind of patient, they are genuinely life-saving. But the science on using them for ordinary high blood pressure moved on a long time ago, and the prescription pad never got the memo. I'm Dr. John Myers, and on this channel, I take the research that has changed and put it in plain language for people over 60, so you can walk into your next appointment knowing more than 12 rushed minutes will ever let your doctor explain. Now, before you decide this doesn't apply to you because your pressure reads fine, that acceptable number is the whole trap. It's the reason a pill can be working against the rest of your body while everyone keeps nodding at the cuff. By the end of this, you'll know 3 things: whether your pill is one of the ones the guidelines quietly walked away from, the specific ways it can work against a body over 60, and the exact questions to bring to your doctor so this finally gets looked at instead of renewed on autopilot for another 3 years. This whole question, a medication that's supposed to be helping you while costing you something, is exactly the kind of thing my patients bring to me all the time about one part of their health after another. So, I took everything I tell my own patients and put it into one simple plan for living longer, stronger, and healthier after 60. 28 of the things that actually change as you get older: your blood pressure, your blood sugar, your memory, your balance. And those are only some of them. Thousands of people are already using it to take back their health. It's already helped so many of them live their best life after 60. Let me tell you what a beta blocker actually does inside you. Your heart muscle is covered in tiny receptors, little docking points called beta receptors. Adrenaline, the hormone your body releases when you climb a hill or get a jolt of stress, plugs into those docking points and tells your heart to beat faster and harder. A beta blocker settles onto those same receptors and keeps the adrenaline from reaching them. So, your heart rate comes down. Each beat pushes with a little less force and your blood pressure drops. That's the whole idea. Now, here's where I want to be completely fair. For certain hearts, that calming effect is exactly what you want. If you've had a heart attack, if you're living with heart failure, or if your heart slips into a dangerous rhythm, then slowing and steadying that heart genuinely saves lives. The evidence for using a beta blocker in those cases is rock solid. I would prescribe one for those patients without hesitating. So please don't hear me saying these are bad drugs. That's not what I'm telling you. The problem is, who else ended up on them and why they never got taken off. For decades, beta blockers were a go-to for plain high blood pressure. You might know yours by its name: metoprolol, sold as Lopressor or Toprol; atenolol, sold as Tinormin; propranolol or bisoprolol. They're cheap, familiar, and doctors prescribe them for blood pressure for 2 generations, tens of millions of prescriptions a year. Then the research caught up with them, and it wasn't kind. In 2005, one of the largest blood pressure studies ever run was published in The Lancet. It was called the Ascot trial, and it followed more than 19,000 people with high blood pressure. Half were treated with a plan built around a beta blocker. The other half were on a different plan built around a calcium channel blocker, a drug called amlodipine, which lowers pressure by relaxing the walls of your arteries instead of slowing your heart. The 2 groups were compared head-to-head for years. The trial was stopped early because the difference between the 2 groups had already become too clear to keep it running. The group that was not on the beta blocker had 23% fewer strokes, 16% fewer heart problems overall, 24% fewer deaths from heart disease, and about a third fewer new cases of diabetes. Those results were strong enough that in 2006, the national body in the UK that writes medical guidelines, an organization called NICE, formally moved beta blockers off the first choice list for uncomplicated high blood pressure. They didn't ban them. They're still recommended for those heart conditions I mentioned, but for straightforward high blood pressure with nothing else going on, they stopped being a preferred pick. And now, almost 20 years later, that's still their position. Here in the US, though, millions of people are still on one as their main blood pressure drug. Usually because a doctor prescribed it a long time ago, it brought the number down, and nobody has revisited that choice since. There's no alarm that rings in your medicine cabinet when a guideline changes. The prescription just quietly renews itself year after year. Let me walk you through the specific ways this drug can work against a body over 60. There are several, and I want you to notice whether any of them sound like your last couple of years. The first one is the one I hear about most: tiredness, and a very particular kind of it. Remember what the drug does. It keeps your heart from speeding up. For a younger person at a desk, that ceiling is invisible because they rarely ask their heart for much. But you're not at a desk. You want to walk the block, carry the groceries in from the car, or get up a flight of stairs without stopping halfway. Every one of those things asks your heart to speed up, and the beta blocker is holding it back. So you hit a wall sooner than you should. Your legs feel heavy. You're winded before you think you have any right to be. This doesn't happen to everyone, but for a lot of people, especially older folks who already have less in the tank to begin with, it's very real. A patient I'll call Lorraine put it to me better than I could. Lorraine is a blend of several people I've cared for, so no one is singled out. She was 72 and told me she had stopped taking her evening walk. Her knees were fine. It was that, in her own words, she was running on half a tank all day, every day. She had been on atenolol for 3 years. Her old doctor had chalked the tiredness up to her age. Nobody had thought to look at her pill bottle. And here's the part that's almost cruel. The single best natural tool you have for lowering blood pressure is movement, walking, staying active. If the medication makes moving feel harder, you move less. And when you move less, your pressure drifts back up. So a pill meant to lower your pressure can make the very thing that lowers it naturally harder to do. If you started a blood pressure drug and your walks got shorter around the same time, that timing is worth a hard look. The second problem is metabolic. The older beta blockers, atenolol and metoprolol, the ones most people over 60 are taking, nudge your body in the wrong direction on blood sugar and cholesterol. They make your cells a little more resistant to insulin, the hormone that clears sugar out of your blood. They tend to push your triglycerides up and your HDL, the good cholesterol, down quietly in the background, while your blood pressure number looks fine. This isn't a small footnote. A large analysis in the American Journal of Cardiology back in 2007 pulled data from almost 95,000 patients and found that people on beta blockers had about a 22% higher risk of developing type 2 diabetes than people on other blood pressure drugs. Remember the 1/3 fewer new diabetes cases from the Ascot trial. Same finding, same direction, over and over. Now, here's the nuance almost nobody bothers to tell you. Not all beta blockers do this. The newer ones, like carvedilol, sold as Coreg, and nebivolol, are built differently. They also relax your blood vessels and are close to neutral on your metabolism. So, if you happen to be on one of those, this particular worry mostly isn't yours. This is really a story about the older workhorses, atenolol and metoprolol, which just happen to be exactly the ones most people over 60 were started on years ago. A quick word about weight. You may have heard these pills pack on the pounds. The honest number is a lot smaller than the scare stories. On average, it's a couple of pounds, mostly in the first few months, and again, mainly with the older drugs. It's real, just not dramatic. But if you're already fighting your blood sugar or your waistline, even a small shove in the wrong direction from a pill that isn't even outperforming its alternatives is worth questioning. The third thing is less a side effect and more a blind spot. A beta blocker often does bring your blood pressure number down. Your cuff reads 128 over 78. Your doctor sees that, you see that, and everyone relaxes. The number looks good. But that number is only one window into your health, and it happens to be the one window this drug keeps looking good through. Underneath an acceptable reading, if it's one of the older beta blockers, your insulin resistance may be creeping up, your cholesterol may be drifting, and your energy may be draining away, and not one of those shows up on the cuff. You can have a beautiful blood pressure and still be quietly sliding backward. A good number isn't the same thing as the right medication. There's one more thing worth mentioning, and I'm going to be careful here because the internet badly oversells it. Like most blood pressure medications, a beta blocker can leave you lightheaded when you stand up too quickly. That swimming, gray moment when you get out of a chair. In an older body, that unsteadiness is worth taking seriously because a bad fall can start a spiral that's hard to come back from. I'll be straight with you. The evidence tying this specifically to beta blockers more than to any other pressure drug is genuinely mixed, but it's one more reason the newer classes are usually the ones we reach for first in seniors today. Before I show you what the evidence actually supports instead, do me one small favor. If this channel has taught you something today, subscribe, tap the like button, and in the comments, tell me two things: your age and the blood pressure medication you're currently on. Just the name off the bottle. I read them, and the pattern in those comments tells me exactly which topics to dig into next for you. So, what does the research actually favor instead? But before I give you a single alternative, I have to stop you because this next part could genuinely protect your life. Do not stop a beta blocker on your own, ever. Not by skipping doses, not by cutting the pill in half because a video told you to. When you've been on one of these for a while, your body adjusts to it. If you pull it away all at once, your heart can rebound. Your rate and your pressure can spike hard and fast. And in someone with an unhealthy heart, that can set off chest pain, a dangerous rhythm, even a heart attack. Coming off a beta blocker has to be done slowly, tapered down over several weeks, typically with your doctor watching the whole way. What I'm handing you today is information and the right questions to ask. It is not permission to open the cabinet and start making changes yourself. With that firmly said, here's what the research favors for a senior whose only real problem is high blood pressure. The first is that calcium channel blocker I mentioned, amlodipine. It lowers your pressure by relaxing the muscle in your artery walls, so the pipes open wider. It was the backbone of the winning side in the Ascot trial. It doesn't carry the same metabolic baggage as the old beta blockers, and it doesn't put a ceiling on your exercise the same way. For a lot of older adults with plain high pressure, it's simply a cleaner fit. The second group is a pair of closely related classes, ACE inhibitors and ARBs. These work on a hormone system that tightens your blood vessels and makes your body hold on to salt and water, and they gently switch that system down. Names like lisinopril and ramipril are ACE inhibitors. Losartan and valsartan are ARBs. They protect your kidneys, tend to do well in people who are also managing diabetes, and are easy on your metabolism. One quirk worth knowing: ACE inhibitors give about 10 to 15% of people a nagging dry cough. Estimates vary, but it's common enough that you should know it going in. If that turns out to be you, an ARB does nearly the same job through nearly the same pathway without the cough. That's usually a simple switch. Now, let me draw the line just as clearly in the other direction because I don't want a single person walking away from a medication they truly need. If you're on a beta blocker, because you've had a heart attack, because you have heart failure, because you have a rhythm problem like atrial fibrillation, or because you get angina, that's a different situation entirely. The evidence for keeping you on it is strong. There's even newer research showing the post-heart attack benefit is clearest when the heart's pumping strength is reduced. So it's worth knowing exactly why you're on yours. The concern I've laid out today is aimed at one specific person: the senior whose only diagnosis is high blood pressure, nothing else, who was handed an older beta blocker years ago and never had it looked at again. If that's you, this is a conversation absolutely worth having. So here's exactly what to do with all of this. Not tonight, not in a panic, but calmly and in order. First, find out what you're actually taking. Go and read the bottle. Is it a beta blocker, one of the names that ends in ol, metoprolol, atenolol, bisoprolol, propranolol, carvedilol? And is it there purely for blood pressure or for one of those heart conditions. If you can't say for certain why you're on it, that alone is worth a phone call. Second, write down 3 questions before your next appointment. The visit is short and you'll forget them in the moment. Is my beta blocker here specifically for blood pressure? And does that still match the current guidelines? Have we checked my blood sugar and my cholesterol lately, given what this drug can do to them? Based on my whole picture, would I be a good candidate for switching to a calcium channel blocker or an ARB? Write those 3 down. Bring the paper with you. Third, ask for a medication review. If you've been on the same blood pressure pill for more than 2 or 3 years and nobody has re-examined it in all that time, you're completely within your rights to ask for a fresh look. A great many people are still taking a medication that was standard practice in 2005 and simply hasn't been reconsidered since. Fourth, if you and your doctor do decide to change something, ask about the taper, that slow, safe step down I described. A careful doctor will bring you off gradually over several weeks and keep an eye on you the entire time. Fifth, start keeping track now, before the appointment. Keep it simple. Every morning, write down your blood pressure reading, your energy on a scale of 1 to 10, and if you check it, your fasting blood sugar, 3 or 4 weeks of your own numbers turns a vague, "I've just been tired," into hard data your doctor can actually act on. That one sheet of paper can change the whole conversation. Lorraine, the woman running on half a tank, her cardiologist eventually did move her off the atenolol slowly, over about 8 weeks, onto a combination without it. And I want to be honest about how that went because these stories get oversold all the time. She didn't wake up 20 years younger, but within a few months her blood sugar had settled back down. She'd dropped a few pounds she hadn't been trying to lose, and she had started taking her evening walks again. She told me she felt like herself for the first time in a long while. Her blood pressure stayed right where it needed to be, steady even. People assume that leaving a blood pressure drug means losing control of the number. For the right person, it simply doesn't. That's the whole point of today. The medication you're on should still fit the person you are now, not just the person you were when it was first prescribed. None of this is me telling you to quit anything on your own. It's me telling you that you're allowed to ask whether your prescription has kept up. Medicine moves. Sometimes the pad doesn't move with it. If this helped you see your own medicine cabinet a little more clearly, do the small things that keep this channel going. Subscribe, give the video a like, and leave a comment. And if someone you love is on a blood pressure pill and dragging through their days, send this to them today. One honest conversation with a doctor armed with the right questions can change how the next 10 years feel. I'm Dr. John Myers. Take good care of yourself, and I'll see you next time.